Good morning, it's 8 o'clock, and we are in week 5 of Cardio-ECHO Tackling Type 2 Diabetes. I'll ask for a couple of reminders here. If you would please type your name and practice location into the chat to record your attendance. If you're not speaking, please remain muted. And if you're on the phone, the mute button is *6. We're going to go around and introduce our speakers and our content experts for today. I'll start. I'm Shannon Switkowski. I'm the clinic coordinator. Dr. Dungan?
Hi, I'm Kathleen Dungan, endocrinologist at OSU, and I'll be facilitating this session.
Thanks. Dr. Perzynski?
Yeah, hi, I'm Adam Perzynski. I'm a sociologist at Metro Health and Case Western Reserve University, and I'm happy to be presenting today on behalf of Dr. Joseph and myself.
Thank you. Dr. Joseph, would you like to go next?
Good morning, everyone. Joshua Joseph. Happy to be here with everyone this morning. I'm an endocrinologist at The Ohio State University and look forward to the discussion.
Thank you. Dr. Beverly?
Hi, I'm Liz Beverly. I am a behavioral diabetes researcher from Ohio University Heritage College of Osteopathic Medicine. I will put my video on in a second.
Excellent, thanks. Sharon Watts?
Hi, good morning. Sharon Watts, nurse practitioner in endocrinology at the VA in Cleveland.
And Karen Bailey?
Hi, I'm a dietitian and certified diabetes educator, or more known as certified diabetes care and education specialist now, with the Ohio University Diabetes Institute.
Thank you so much. And Dr. Dungan, I'll turn it over to you.
Well, good morning, everyone. We have a really great presentation and case planned for this morning. Just a few points of order before we begin. This is the structure of our clinic today. We will have a 25-minute didactic presentation followed by question and answer. And during that question and answer session, remember that you can put some questions into the chat box, but we would love it if you would turn on your cameras so we can see and we can really interact. And you are free to unmute your microphone at that time. Following the didactic presentation and discussion will be a case study and discussion. And similarly, we ask you to turn your cameras on and have some discussion with the group. And then finally, we'll have our wrap up. And please remember to complete that post-clinic survey, very important. All right. So with that, here's our disclosure statements. Those were sent to you by email as well. And we will move on to our didactic presentation of the day, which will be presented by Dr. Adam Perzynski and Dr. Joshua Joseph. Dr. Perzynski, go right ahead.
Adam, you might be on mute.
Yeah, there we go. Is that
Okay.
better? Okay, great. So I'm really pleased to be able to share with you this presentation that Dr. Joseph and I put together. Fair warning, there might be one or two of you who joined the Diabetes Quality Improvement Program session about a week ago. And so for those of you, this will be a little bit of review or refresher. Our objectives today are to talk a little bit about subpopulations at risk for type 2 diabetes and to really talk about root causes or fundamental causes of type 2 diabetes, and then to talk about an approach to communicating about diabetes management in minority populations. So this first slide is really designed to show what I've described here as a continuum of diabetes. And diabetes can be thought of as having multiple layers of health disparities, all the way from the left side of your screen there at the incidence and prevalence of diabetes to detection and diagnosis, clinical management, self-management, severity, hypo or hyperglycemic events, glycemic control, severe complications, cardiovascular events, and mortality. There might be a few more boxes you could squeeze in here, but that was how many I could fit on the screen. But among health conditions where we see disparities by socioeconomic status and by race and ethnicity, diabetes is somewhat unique in that there are observed disparities published in the literature at pretty much all of these layers, which makes it a particularly vexing condition in that regard. This paper that I've cited in the center of the slide from Diabetes Care highlighted a few, in addition to some clinical management strategies, they made some recommendations about how to address disparities in diabetes care. And the three that they really highlight are that providers need to assess social context. That includes food insecurity, housing instability, financial needs, and incorporate that social context into treatment decisions. They highlight that patients should then be referred to social and community resources when those are available, and that patients should be provided with support from lay health advisors, peers, navigators, or community health workers. So we're going to talk a little bit about the root causes of health disparities in diabetes. And this is just a quick outline. We're going to go through this excellent 5 whys exercise from our colleague Chris Jordan, talk a little bit about communication, social needs, and then cultural humility, implicit bias, and discrimination. So this is just a method for determining the underlying reasons or root causes of an event or occurrence. It's a nice, quick way to help you reflect and think about those things that are maybe not so apparent at the first look. On the other hand, this is not really an empirical exercise. It's really more of a philosopher's game, but it can be very useful. So 5 whys is simply asking why 5 times. So here we have a patient, say in our clinic, who did not attend his follow-up appointment, and we would ask the question, well, why is that? And the first answer we might come up with is, well, the patient did not believe that he needed to come in for his visit. Well, why did the patient not believe that he needed to come in for his visit? The patient did not feel any discomfort, and so he determined that the appointment was unnecessary. All right, well, why did the patient determine that the appointment was unnecessary? Well, this particular patient does not understand the need for monitoring and follow-up care. Well, why does this guy not understand the need for monitoring and follow-up care? Well, this particular patient was focused on short-term relief of symptoms and not on a long-term treatment plan for his diabetes. Well, why is he only focused on short-term symptoms rather than a long-term treatment plan? Well, here we're getting at a root cause where the reason was that a cultural norm in the culture that this particular patient is from was to only ever see a doctor if and when there were visible and uncomfortable symptoms occurring. So he comes from a particular culture where there is a scarcity of healthcare resources, and it was a normal behavior to only use healthcare services when you're having uncomfortable symptoms as a way of sort of personal rationing, which would be different from most of our healthcare settings that we're all familiar with. So this is just one example of how you can use 5 whys to get at some root causes of differences that we observe among patients in clinics. Another example here that I'll fly through more quickly is a patient who did not take their medication as described. Why? They didn't get the prescription refilled. Why? They didn't have money for the copay. Why didn't they have money? Because they spent their money on housing. Why did they spend their money on housing? Because the rent in their mobile home went up dramatically. And why did their rent go up? Well, because we have structures of housing for low-income people and middle-income people that are really vulnerable to changes in local property investment strategies that have very little to do with things that are under their own control. So identifying root causes is important because it's looking at more than just fixing the symptoms that are showing up and can help with explanations. It's important to ask why in this framework at least 5 times. And this exercise can help us think about how social factors are often fundamental causes of disease and disparities. So by asking why repeatedly, we often end up at these fundamental social explanations for health outcomes. This slide sort of sums it up nicely from this work that was done by Anna Giroux and her colleagues, where they looked at the outcomes in diabetes and how disparate outcomes can be traced to a combination of social environmental circumstances and the built in the physical environment. So sort of removing in this figure that layer of self-management and personal decision-making, and really describing differences as traceable to things like healthcare access, family supports, nutritional environments, like whether someone lives in a food desert or is experiencing food scarcity in their household, whether they live in a place that is safe for exercise, whether they live in a place where tobacco use is highly prevalent, and whether there's lots of noise or environmental pollution. This is another excellent description from Dr. Joseph that really lays out a couple of, I sort of like to think of this figure as 2, it's more than 2, but as 2 main pathways. And what I like about this particular figure is that it recognizes the historical basis for racism and discrimination and their effects on cardiovascular disease outcomes, including diabetes, and how those disparities were generated. But in particular, the box at the top left recognizes the clear involvement of medicine and science in this history. And so there are some clear examples. The third bullet there is experimentation on vulnerable groups without their consent. And an example of that would be the Tuskegee study, where African Americans in Tuskegee, Alabama, were untreated for syphilis for a period of about 30 years after antibiotics were available to treat them, because they had been participating in a long study. And really the cause of that decision to not treat those men was racism. So that history then leads to differences in trust in the medical establishment, communication barriers. Current biases can also be traced to that history. And so then downstream, that leads to lower care quality because we have poorer trust and poorer communication with a subset of our patients. The box at the right is talking about social conditions and policies that not medicine and science are not necessarily directly involved in, but that continue to this day to lead to disparate outcomes. Some of my own research in Cleveland has focused on how redlining and discriminatory lending in the 1930s has led to the social conditions in neighborhoods today, which influence people's health outcomes. So I want to talk a little bit about patient-provider communication. So we know that self-management is really essential for multiple chronic conditions, and diabetes especially so. We know that patients with diabetes need to eat healthy, be active, monitor their blood sugar and their blood pressure, take their medication, solve problems, reduce their risks, and cope with adversity in order to care for their diabetes. However, we know that these challenges in self-management are made more difficult by challenges in communication that vary across income and across race and ethnicity, And the right-hand pane of this particular figure is particularly striking. This comes from the Medical Expenditure Panel Survey. And if you look at the black line in the right-hand pane versus the light blue lines, or the circles versus the diamonds, what you see is that the gap in poor communication has actually been increasing between low income and high income individuals, and that it's about 3 times as high, the rate of patients who report poor communication with their healthcare providers when they are in the lowest income versus the highest income group. We see similar but lower magnitude differences by race and ethnicity. So oftentimes we're asked, well, how much do these differences have to do, these differences in health behaviors have to do with the specific circumstances of whether there is concordance between the sex and the race ethnicity of a patient and a provider. There has been a little bit of literature on this, and I'm going to highlight a couple of those studies, particularly this trailer study, which first shows in this figure that there are some important differences in the rate of adherence by race and ethnicity, with white patients having the highest rate of adherence and racial and ethnic minorities all having lower rates of medication adherence to cardiovascular medications. What we also know from that study is that when we look at concordance by the race and ethnicity and language group of the provider versus the patient, we see an interesting trend whereby primary care providers who speak Spanish and have patients who speak Spanish, their patients have higher rates of adherence to cardiovascular medications. We also know that when Black patients have a Black PCP, they have higher rates of adherence to cardiovascular medications. The differences are not tremendously large, but they are important differences. However, this evidence on concordance is far more complicated than those differences. First, a systematic review study of about 20 studies on concordance concluded that patient-provider race concordance is not necessarily associated with more positive health outcomes for racial and ethnic minorities. And then there's this other experimental study that's really pretty fascinating, the second bullet here, which showed that communication rated as more collaborative in race discordant relationships, so where the race of the provider and the patient were not matching, was associated with better adherence, while communication rated as less collaborative was associated with poor adherence. And there was no significant association between adherence and communication in race concordant relationships. So effectively what they found is this sort of moderated relationship, whereby in race discordant relationships, if providers used effective communication, then they were able to overcome the barriers of those differences in racial and ethnic background. So further experimental studies also suggest that race and sex discordant providers who practice empathy, collaborative communication, and self-disclosure can build similar levels of trust as concordant providers. What do I mean by self-disclosure? So this is a really simple experimental study where the providers were simply guided to self-disclose their own lapses in behavioral self-management. For example, if a doctor were to say something like, "We all forget to take our medicine sometimes, especially me. I also forget to take my medicine sometimes. How often do you forget to take your medicine?" So that sort of self-disclosure by a care provider was found to build similar levels of trust across racial and ethnic boundaries versus providers who did not self-disclose some of their own lapses or vulnerabilities. So looking at, oops, I went a little too far ahead. So we're going to look a little bit at non-medical health related social needs. So we know that there are big differences in the rate of who has these social determinants of health in clinical settings. We know that the lowest income folks have the highest rates of social needs. This is just a simple example of difficulty paying medical bills by income on the left-hand panel and by race and ethnicity on the right-hand panel. And the important thing there to see is that while there have been improvements for all groups, still we're looking at 2 to 3 times the rate of difficulty paying for medical expenses for folks who are in the lowest income groups and for folks who are Black or Hispanic versus the highest income groups or versus whites and Asians.
Sorry, Adam, just a quick question. Do you know what sort of bills those might be? Are they medications or something else?
Yeah, so this is the National Health Interview Survey. So this is sort of all medical expenses. So it's a really, really broad question, which is, did you have trouble paying for medical expenditures that you needed? I think it's a very, very broad general question in NHIS. There are far more specific studies that ask better questions about sort of whether it's prescriptions and then the other challenge here is that, I think you're alluding to, Gautam, is that there's a real difference according to maybe where you live and what type of plan you're covered under. So if you live in a state that has expanded Medicaid, and of course this is national data, so that persons who live in states with Medicaid expansion would have differences. Also, you note that this data only covers 2 years of post-Medicaid expansion. So there are a lot of complexity that's really not covered here, and I think it's good that you pointed that out. Certainly that's not the only example, but we don't have time to go through all the pieces here. This is sort of a quick survey overview. When we think about cultural humility as opposed to cultural sensitivity, the difference here is that cultural humility has been defined as the ability to maintain an interpersonal stance that is other-oriented or open in relation to aspects of other people's cultural identity that are important to them. This is a more empathetic version of bridging cultural differences than another phrase that's often used, which is cultural competence. Cultural competence, and sort of the word competence implies that there's some level of attainable competence that we can all reach. But there might be some interactions where we don't reach, we live on a planet full of folks from many diverse backgrounds. And I think in some ways it's a little bit arrogant to assume that we could reach some level of competence for every combination of culture, race, ethnicity, income, every combination of difference that we would encounter. So a more empathetic cultural approach of cultural humility is something that we advocate for. And what does that really mean? Well, there's this assess framework, which is useful from Lisa Boson, which is ask questions in a humble and safe manner, seek self-awareness, suspend your judgment, be kind, support a safe and welcoming environment, and start where the patient is at. These are all things that I think many providers are practicing on a regular basis anyway, but I think thinking of it in this cultural humility framework is important. So I'm going to do a quick overview of some potential pathways and solutions. There are lots of possible solutions. This is not meant to be a comprehensive overview. This is sort of just a quick rapid fire summary. So one step is to mitigate implicit bias via effective communication and building trust. I sort of mentioned one pathway in the interpersonal framework, but another layer that Dr. Joseph has really highlighted in some recent work and that others have highlighted is that each of us can strive to make anti-racism a core value in our organizations. And so that means, really acting to elevate the cause of anti-racism in your organization, engaging stakeholders, taking seriously things like have happened in Ohio, like in Cuyahoga County and in Franklin County, where we've declared racism a public health crisis. Like taking that seriously, it's not just a newspaper headline. It's something that we need to think about within our organization and work toward really building community and empowering those who are marginalized or oppressed. Another set of actions we can take is really around this language of noncompliance and non-adherence, which denote a passive or obedient role for patients. And, you know, almost feel a little bit blaming from the perspective of patients. We really want to be empathetic and non-judgmental. And I know that Dr. Warner is going to talk about motivational interviewing, and there are some really great strategies that Gotham has given already and will continue to give throughout the ECHO session that really embody what this collaborative, empathetic relationship looks like. Next, many of you know the National Culturally and Linguistic Appropriate Services Standards, the CLAS standards. So basically what this means is that we want to advance health equity at every point of contact, especially for language minorities. People should have the ability to receive care in their own language, even if it's via a translation service, and they should not have to pay for that. And there should not be extra special measures that, you know, they shouldn't have to only come to clinic on Sunday afternoons when the translator is available. We shouldn't be creating additional barriers for persons who speak English as a second language or do not speak English or do not read or write well. We want to, another layer, many of you have seen or are already in your clinics beginning to do these referrals and screening for social needs. There are vendor-based systems like the Pathways Community Hub. Most of you have an electronic health record that has something built in. I'm sure that some of you are using it and some of you are not. So thinking through those local quality improvement projects that you could run to say, like, how do we really fit social needs screening into our clinical workflow? Talking to other care organizations that have done so. And then this last point I've discovered in some of my recent like QI work and teaching, that when you talk to healthcare providers, they're actually doing an immense amount of social care already in their clinics. And my favorite example is forms. If you think about these home energy assistance or HEAP forms where folks need an air conditioner, or so this is somebody who doesn't have money to pay for the energy that they might need to heat or cool their home. And a provider has this immense power to complete a form that can suspend their need to pay for that or even receive a free air conditioner. That's one example of dozens and dozens of forms where healthcare providers have immense power to negotiate relationships across sectors and really meet social needs. So thinking about those not so much as a burden, but really as an opportunity to meet the social needs of your patients. And lastly, I wish we had a ton of time to talk about community health workers because they're such an effective and interesting pathway, especially here in Ohio. I know that Carol Wayland Smith at Ohio State University has this awesome report on community health workers. Community health workers are frontline public health workers who are trusted community members who possess a deep understanding of the communities they serve. They really are able to serve roles that doctors and nurses and other clinicians in a clinic are often less able to serve. And they're really a complementary role that can work with and interact with people with diabetes. There's quite a bit of evidence in diabetes that community health workers improve outcomes and reduce disparities. Some examples here, one other thing that we know, and this will be just about the last slide, is that the community health worker interventions that are the highest intensity are those that are the most effective. So that if you're doing sort of community health worker light, and all you're doing is having your CHW make one reminder call per patient, that's probably not going to do it. On the other hand, when CHWs are in a more intensive framework where they're delivering long-term interventions that include home visits or intensive self-management training, that in those situations, I think across multiple studies like this, the numbers that change in A1C control is between 0.5% and 1% reduction in A1C. So really substantial change in A1C with community health worker interventions. So there are lots of other potential solutions to health disparities in diabetes. It's really critical to think through those things that at your clinics are and in your community are driving health disparities using something like the 5 Whys exercise and thinking through what's really relevant in the hyper-local circumstances of your clinic. Just looking at the great list of people participating today, we have folks in urban primary care clinics that serve a particular racial and ethnic community. We have folks in rural communities. We have folks in large systems. We have folks in small primary care practices. So really thinking through those aspects that fit your work are particularly important. And so I think we have time for just a couple of questions, and maybe I can take a look at the chat or someone can read those off.
Great, thank you so much, Dr. Perzynski. Yeah, we are getting some questions in the chat. I do want to pull in Dr. Joseph here too. Dr. Joseph, could you give us, a quick kind of overview on some of the interventions that you've seen recently in terms of reducing disparities and what your perspective was?
Yeah, so thank you so much, Kathleen, for that question, and thank you everyone for attending this session. This has been a great session. Adam, that was a fantastic job. Before I get to the disparities piece, I think that one of the keys that I see, I guess this isn't disparities piece, but one of the keys that I see is how do we build both effective and trusting relationships with patients. When we think about diabetes, I think what is different about diabetes is that diabetes and diabetes care, A1C, et cetera, are impacted by everything someone does in the day. What time you wake up. What do you do when you wake up? Do you eat? Do you not eat? Are you sitting? Are you not sitting? Do you exercise that day? Do you not exercise that day? Are you stressed? Are there external stresses that are impacting you, or internal stresses that are impacting you? And so when I think about diabetes and I think about diabetes care, because it is impacted by everything someone does from the time they wake up to the time they go to bed, and even overnight activities like sleep apnea, we really have to build effective relationships in order to address all the various issues that occur in a day for someone with diabetes. And so I think that, more and more we see this being built. We see this being built into different interventions, is how do we effectively do that? But one of the pieces that, I'm really interested in is how do we really mitigate implicit bias in care? And so many of you know Dr. Quinn Capers here at Ohio State, who's led some very effective implicit bias work around blood pressure, as well as things like medical school admissions. So how do we integrate that as one simple piece to that? And I'll say that, for me personally, I'll actually give the opposite perspective. I see a lot of patients that are disconcordant from myself. Maybe they're from Appalachia or from Southeast Ohio or Southern Ohio. And I have to work really hard. Is that I often look at where their hometown is. I was fortunate my family was in housing, so I visited a lot of the towns in South and Southeast Ohio, and I talk about their high schools. I talk about the rivalries that are ongoing. Just trying to build that bridge. What are the commonalities between themselves and myself, where we can build concordance that for me may not be racial ethnic concordance, but how can I still build concordance with that patient?
Great. And there is a question here in the chat. Maybe Adam or Joshua, you could address this if you can. Do you have suggestions for how to get a diabetes community health worker funded?
So I think this is a real challenge for many organizations in the state right now. I think that right now the groups that currently employ the greatest number of community health workers are actually the managed care plans. One way is to work with your plans and talk to them about what resources that they have available, because some of the plans, and sort of depending on what location you're in, have immense community health worker resources that they are actively mobilizing. I know that at the At Tri-C, for example, here in Cuyahoga County, nearly all of the recent graduates of their community health worker program who are certified community health workers were scooped up in the recent cohort by the plans because the plans value their work so highly. So I think that's one mechanism, is to work with the plans. I'm not sure if others have other suggestions.
This is Mark from Metro Health. I actually worked as not a certified, but an uncertified community health worker prior to being a physician assistant with Asian Inc. In Cleveland. And I believe they leverage Medicaid somehow, but also community behavioral support specialists can be funded through Medicaid and I believe Medicare if there's a psychiatric diagnosis, is my understanding. But I'm a huge fan of community health workers as well.
The other place to, this is Sherry Bolin at CASE, the other place to look at is if you have a hub pathway in your area. And so I think there is now 6 across the state. So I'm not sure, Christine, where you're from, but Columbus and Cincinnati and Cleveland now and Toledo all have hub pathways. And then community health workers can get paid through working on social determinants of health with a particular client. And what we've been doing in our group here is you can have a health system that has a community health worker or a clinic, and that community health worker can be part of the hub and get paid to work with the patient. So it's a model, and I'm happy to connect you if you have interest in that, but that's just one model for payment. The other is using your value-based payment contracts to get to work within your health system to get a community health worker hired as part of, improving total cost of care and managing your patients. So that's just something to consider as well.
I meant to add that under the psychiatric program that I worked in briefly, it was it was time-based. You had to record down to the minute your interactions with the patients. So that's one challenge, but it's also an option.
Thank you, Mark and Sherry. Other questions? I guess I'm curious as to the type of training that is involved with community health workers. And I'm assuming that training probably is not the same depending on what area of expertise that you're going into.
Yeah, so I'll say a little bit about that. I know there's others very experienced with this on the call as well. Here at Ohio State, in our College of Nursing, we have a community health worker training program, and the training that I've seen and worked with them on is very broad-based, really addressing all of those social determinants or non-medical health-related social needs that Adam was kind of describing earlier. And then we can have some focused training. So, for instance, Sherry was mentioning, kind of community benefit dollars, value-based care. We've done that as well here. And so in those instances, like let's say someone's going to be a community health worker for cancer, we do some additional training around like cancer prevention or cancer treatment or cancer survivorship, et cetera. So it's really a combination of more general training around those non-medical health-related social needs and then specific training targeted to the area that they will be addressing.
I would just add one quick thing to what Dr. Joseph mentioned, which is that some of you may or may not be aware that community health workers and the community health worker programs like the one at Ohio State and at Tri-C here in Cleveland and other organizations are certified and have a scope of practice that's regulated by the Ohio Board of Nursing. So unlike in in fact, most states in the United States, where it's a little bit of a sort of free-for-all in that training programs are unregulated and there's not a clear scope of practice, Ohio is far ahead of many other places in having a defined scope of practice and really these consistency in training and training programs. So I think you can have a lot of confidence in folks who are coming from those training programs.
It's really great.
Yeah,
to know.
Go ahead, Joshua.
Oh, no, go ahead, sure, go ahead.
I was just going to say, we've been speaking, we're working on trying to look at some policies to put in place at the national level, or recommendations to Congress around community health workers. So we've spoken to probably 6 or more stakeholders that the National National Association of Community Health Workers, and then the University of Pennsylvania, where they sort of started and did a lot with community health workers. So the only thing I would say about the training and scope of work is that it's really about hiring the right person, and it's when University of Pennsylvania describes this, it's the magic of a community health worker is having that, not just that trusted person from the community, but they're somebody who can really relate to the people, and it's sort of, their communication skills are quite good with the community that they serve. And it's not just training, it's hard to train someone for you have to be the right person, just like just like many positions, you want to hire the right person. But I think in particular, certification may, if we have standards around certification, that may lead to people not being able to help their communities who are outstanding community health workers. So I just want to put that, just sort of state that, and also that there's going to be national standards that the NCQA is going to be developing that should come out in February of 2021 that may help people as well. And there's lots of implementation toolkits around, what you need to have sort of to do in terms of evidence-based approaches, because I agree that having a community health worker, just hiring somebody without sort of the right supervision and oversight and acclimation is not going to just magically make things happen. So Josh, I don't know if you wanted to add to that.
That was perfect. That's exactly what I was going to bring up. So that is perfect. They have to be someone who understands and relates and to the community, can build relationships with individuals within that community. When we look at the program here, they actually are recruiting some of the individuals into the program who were previously involved in the correctional facilities, et cetera, who have some history of being incarcerated, et cetera. And so there are some diversion programs we have where they can actually go into community health worker programs. So we're really thinking about really involving people from all kind of arenas and areas of life, but people who can go back into communities and understand that community with that additional training and build those relationships. So yeah, couldn't have said it better myself, Sherry.
I have a question here from Five Rivers, Jim Lamb. On one of Adam's slides, there was a statement from the ADA about the use of patient navigators and a recommendation. And I know in cancer treatment, when they've had navigators come into the office with the patient, sometimes the adherence is better because we hit them with all this information. Even with instructions, they walk out, and a couple papers I think showed that they didn't remember a lot of what we said, and therefore the adherence is going to be lower. So are there programs for patient navigators in diabetes specifically, and how do you access them and get some people involved in the clinics, especially these lower income clinics that we're working with?
So I think in Ohio, there's some fluidity between the terms community health worker, patient navigator, peer support worker, and in other places where there's been some, there's tremendous interest in folks who serve these important roles in care. I think that Ohio has gone with and sort of placed a stake in the ground around the term community health worker and around that framework. But those folks in those programs would certainly serve the same role that I think, or could serve the same role that you're mentioning, that has been demonstrated to be successful in cancer care. The one difference is that I think a lot of the cancer care studies have focused on screening and promotion of screening, which is a little bit of sort of community health worker light, because you're really trying to get someone to take one action as opposed to, what Dr. Joseph was mentioning, which is this like every action your whole day from, when you're asleep to when you get up, every meal, your activity level, your stress level. So I think that there's a little bit of a difference there, especially because the research literature tends to show that it's those more intensive interventions that have the biggest effect, as opposed to these smaller things that we've seen more of in cancer care, which is that a community health worker consultation can drastically improve uptake of screening. But that's sort of like a one-off, like, that's great, we accomplished the screening. But that's less of sort of integrating a set of behaviors and self-management practices over a long period of time.
Well, thank you everyone for that great discussion. I'd like to segue now to our case. What have been some of your approaches with patients who are blind or have other disabilities?
It usually hits people between that 30 and 60 when they have that family history of macular disorder. Yeah. But no, it was not related to diabetes. And even had diagnosis, her diabetes, her A1C was 8.1, and then consistently it had stayed around 6, under 7 after the metformin. I did think of GLP-1 maybe in future too, considering the current guidelines, regardless, independent of the A1C, but she is not willing to make any changes at this time, and she is, like, her sugar levels are controlled with metformin right now, and that's what she's comfortable with. So I didn't want to be too aggressive right now with her.
This is Sharon. I would say at the VA, we have a whole blind center that has a lot of equipment for patients and helps them to remain independent. But that's the first thing I would have done. You did a great job getting her on a CGM that she can use. I guess, did I hear you say she's still on sulfonylurea as well?
No.
Oh, okay.
Just
yes.
metformin mixed dose, yeah.
I would have been concerned about low
Yes.
blood sugars, but she sounds well controlled, so great.
This is Karen. I really like the fact that you downloaded an app so that the app reads the device. And
yes.
Yeah, that is so cool. And I like that you were able to do that. Now, being a dietitian, I'd be concerned too with how she gets her meals if she's blind. And she has a support person that's helping support her get meals to her. And if she didn't, then I would probably be reaching out to organizations that can maybe deliver meals or hook her up with assistance. And again, the Area Agency on Aging, is very familiar with programs, and that's their job to help people in situations like hers. And then as far as activity, we know being physically active at whatever level you can that's appropriate really helps with diabetes management and with arthritis. So sometimes I have asked the patient, have you considered maybe doing some physical therapy or having a physical therapy work with you and help you with, develop a plan of exercises that will benefit you and that you can tolerate. So I think sometimes they're underutilized, the physical therapists, but if, that might be an option so that her arthritis doesn't get worse.
Thank you. Yeah, those are great recommendations, and definitely something we would work with her over the years. Yes. And just to clarify, for her food, I do believe she is involved with an organization for the food to be delivered to her, and she also has home health care that checks on her every week or twice a week. But then she has this friend who primarily is the primary contact for her to check on a daily basis. So I trained her as well, just in case if she had to help her with the sensor patches or anything. But she is very independent person, and she wants to remain independent. So that's why we made sure that she could do everything comfortably by herself.
This is Joshua, and I just want to say regarding the medical management piece, I agree with your comment about a GLP-1. I think, you said she had a ASCVD risk of 47%. You also said she had a BMI of 38. And I also think you mentioned that she had arthritis. So, with some weight loss, that the arthritis may improve too. So I think multiple domains there. And then lastly, I think you said she had a GFR of 43. And there's, some data, not as great as SGLT2 inhibitors, but there is some data that the GLP-1s help to stabilize the GFR long-term as well. And most of them, you don't have to dose based on kidney function. So I think, I agree with you on that if she'd be willing to do that over time, I think that would be potentially a nice complement to her therapy.
Sure. And maybe a once weekly one. That way she can do it on the day the home healthcare is there and she doesn't have to worry about injecting herself either. Because that was a primary concern with checking sugars. She can poke herself, but then she can't see her blood, so she couldn't use any traditional glucometers. And that was making her more anxious, not knowing.
Yeah, no, 100% agree with that. I don't know, Kathleen or others had comments on that piece.
Yeah, the SGLT2 inhibitors probably won't affect her glucose control at this eGFR, but at least all of the CV outcome studies and renal outcome studies like Credence have enrolled patients with eGFR down as low as 30. And so she would qualify in terms of that, even though the labeling may not include eGFR of less than 45. There is another comment, even though she, from Mary Lee Clemens, even though she has Medicare Part D, you may be able to get GLP-1 through medication assistance programs to minimize costs.
Yep.
Yeah.
Yep, we'll definitely look into that. She has an appointment coming back on November 8th. So we just actually got her glucose readings this week and they look okay, but we'll definitely, to help her with our other comorbidities, it would definitely help, sure.
So other comments, questions?
I had one other question, and this is because I had a very similar patient last week, and we were trying to find apps. What is the app that you used, the AI app that will read the CGM there?
Hold on 1 second because I pulled it up. Let me look it up real quick.
I've used,
I have. It's Seeing AI. Here. Okay.
Seeing AI.
Can you type it in the chat?
Right. I know I have experience with a Dexcom patient also, so I think these kinds of tools can be used for other CGMs as well.
Sure. I think in this case, like I worked with both as well, Dexcom as well as Freestyle Libre, and knowing that Freestyle Libre has specific ridges on where would you pick up the sensor, like all of that was easy in terms of feeling and understanding compared to Dexcom in this case. But yeah, I love that.
Interesting.
Used it with other patients, yes.
Yeah, and there is more to manipulate with the Dexcom because you're having to take the transmitter apart and keep the transmitter, whereas with the Libre in this case you just kind of toss the whole thing. So maybe that's
one thing that I have figured out over the last few months and that I personally don't like about Dexcom is when patients don't have phones compatible for the app and they're only using the receiver, which only stores 24 hours worth of data and a graph. Like the patient, if I call patients a bi-week or once every 2 weeks or once every month to check on the readings, and if they're only using a receiver, they can only go as far as 24 hours unless they wrote it down. So that's the one thing I don't like about Dexcom receivers. But if it's connected to their app with the phone, they work great.
Yeah.
And then Kathleen, there's one question in the chat about depression related to blindness.
Yes. So she's currently, so the question is about her depression related to blindness and if the patient has access counseling and is she taking medication. She's not open or willing to take medication for that as well at this time, but yes, she is with counseling. And she has, like I said, support at home as well from her close friends and not sure her family is that much involved or not, but to help her with that as well.
Well, great. Thanks everyone for a great conversation. Shannon, I will hand this over to you for our wrap up.
Thank you so much. I'll be quick. Today's the last day to update your contact information. You would have received a survey from RedCap this past week. If you would like to opt out, please email me sometime today. Otherwise, we'll just share your name, your email, and your practice location with this cohort. Next slide. You can always watch our previous clinics on the website. You just have to register to be able to access the content. And finally, please complete your post-clinic survey by Friday at 5 p.m. At the end of the series, we'll send information on how to collect CME credits if you wish to do so. And next week, we have a topic of motivational interviewing in the context of type 2 diabetes, and Dr. Jim Werner from Case Western will present that topic. So we'll see you next week. Everyone, have a great week.
Thanks, everyone. Goodbye.
Thanks for coming.